We ready? Good morning. How are you both?
Good.
Good. Well, thank you so much for coming. My name is Nicole Disch, and I'm a nurse practitioner with MercyHealth. I currently work at Mercy Walworth, down on 67 and 50 with Dr. McCoy. We see patients 18 years and older with attention to the geriatric population. And I was asked months and months ago to present on depression, specifically depression in the aging population. My background, I've been a nurse for 20 years, a nurse practitioner for the last 6. Much of my background in medicine is in oncology and palliative care, so I have a lot of experience in patients with depression. I've got just a little personal info. I've got 2 kids, 4 bonus kids. There we are on vacation this summer. In my free time, I like to exercise, travel, and do all things kids sports. But more importantly, today, what I like to cover is some basics and, how we, come ahead, but what we classify depression as, how we treat it, what the risk factors are, and what we can do about it in a clinic setting, and how you can manage symptoms at home independently. But my objectives today are to define what is depression, what are the risk factors, signs and symptoms, how we diagnose in the clinic, how we treat, can we prevent, and then how do you support family and friends that have depression or signs of depression. Any questions you might have, let's make this informal as possible. So if you want to stop me, have a question, a personal experience you want to share during this discussion today, I think it's great just to be open rather than me giving you all the info. So how do we define depression? Depression is a serious mood disorder that affects the way we think, we feel, and we act. And interestingly enough, it's not a normal consequence of aging. I think too many people link depression in the older adult, like just we expect to be sad, or we expect to, slow down and not feel as well as we did when we were youthful. But certainly it's not a normal consequence of aging. Sadness and grief are. So there are certain things in life events such as aging, bereavement, adjustment to changes in your social status, potentially moving into retirement, losing income, being on fixed incomes, transitions to independent living, assisted living, or residential care, and the loss of just physical, social, cognitive function. So those are, they can be more common and normal responses to life change, but certainly depression is not a normal consequence of aging. I think depression is always a hard topic to discuss too. I think there's almost like a taboo, especially in the older adult. We never want depression to make us feel like we have a mental illness. I think there's a lot of stigma behind that. So I always talk to patients that there is a true physiologic change in the brain that causes depression. So feeling sad and things like that, everyone thinks, well, I should feel better, I should feel happy. They feel guilty that they have these thoughts. But there's actually true change in the brain that can cause depression. Cortisol, so cortisol is a stress hormone in the body. And when the body's under stress or sad, cortisol levels actually rise in the body. So they rise and the brain gets flooded with all of this cortisol. And the hippocampus, which is a part of the brain that helps control emotion, actually stops growing, or it slows down and it causes it to shrink, and then patients have memory issues. And then there's another part of the brain called the amygdala. It's the pleasure center of the brain. When cortisol influxes the brain, the amygdala actually enlarges, and this causes sleep disturbance, changes in activity, and other changes in other hormones which have effects on the body. So it's true physiologic change in the brain that can cause depression. Risk factors. So what are the risk factors for depression later in life? As I just mentioned, changes in the brain certainly may affect our mood and result in depression. And then there's other experiences that we have in life. Major life events like medical diagnoses or loss. Many women and men in the later stages of life are caregivers to their loved ones, and certainly that causes additional stress and can lead to depression. And then other times there's no reason at all that people become depressed. But here are some risk factors that I like to talk about. Certainly patients with a lot of medical conditions, loss of function. We grieve the loss of health. It's a natural phenomenon. But there's a genetic component as well. Sometimes patients with family histories, moms, dads, brothers, and sisters with depression or mental illness, those folks are at risk of having depression later in life. Stress. Stress can certainly cause depression. When patients aren't sleeping well, when they have insomnia, sometimes that can lead to depression. Social isolation, feeling lonely, the lack of exercise, physical activity, which sometimes we can't change. When we hurt, when the body hurts, when we're not able to be as active as we once were, that can contribute to feeling sad. Functional or cognitive impairment. Women are at a higher risk than men of having some depression. And then when we're widowed, or we're divorced, or we're single, that certainly too increases our risk. And then those with lower socioeconomic statuses. So those that don't have as much income, certainly at higher risk are well. Welcome, thanks for coming. And then those that generally or routinely participate in alcohol or substance abuse can also be at a higher risk of developing depression later in life. I was telling the ladies, we're making this certainly super informal, so stop me, chime in, anything that you guys want to make this educational and enjoyable. Signs and symptoms. So depression, signs and symptoms. Interestingly, in the clinical world, older adults have different clinical symptoms of depression than the younger adult. And oftentimes, it's harder to diagnose in the older person. But typically, I like to talk to patients about, what leads us to a diagnosis of depression. Persistent sadness, anxiety, empty mood. I talk to patients about if these feelings last and don't change for 2 weeks or more, that's, worrisome for me as a provider, and I like to intervene. So 2 weeks of not feeling good. Some days are good and some days are bad, and that's, I guess, that's life. But if you consistently feel not well for 2 weeks or more, then I think let's do something about it. Quality of life is huge, and if we can make your mind feel better, because of course it's mind over matter, and your mind is so powerful, so if we can change that, certainly just your overall quality of life improves. But patients that feel hopeless, guilty, worthless, helpless, those that are more irritable, restless, having trouble sitting still, loss of interest in once pleasurable activities. We call that anhedonia in the clinic setting when, things that you used to love, you just don't care about anymore. And that concerns me. And that's actually one of the things that I ask patients about when they come see me is, hey, what did you used to enjoy that you don't anymore? Because that's one of the things that certainly leads to a diagnosis of depression. If you have decreased energy or fatigue, you're moving or talking more slowly, if you have trouble remembering things, difficulty concentrating. Sleep is big as well. I talk to patients about their loss of interest, and then we talk about what other things are going on. And often folks will tell me, I'm not sleeping well, or I'm sleeping all the time. Or they'll say, I'm eating so much more than I used to, or I have no appetite. So weight changes also kind of lead me to a diagnosis of, hey, something's going on. There's something more to the story that we need to discuss. And this is always hard for me to address, but when I think about depression in the older adult, suicide also happens. And again, this is certainly not something that's easy to discuss, but I think it's important to, know that suicide also happens in the older population. And so if you have several signs of these symptoms that we just talked about, I thoroughly encourage folks to chat with their healthcare provider. Call the doc and say, hey, I'm having a rough time, and I want to sit down and talk to you about it. Because certainly we can do things in a clinical setting to make you feel better. So like I said, this is uncomfortable but so real that I thought I wanted to at least draw a little bit of attention to it, because knowledge is power. So depression is a major risk factor for suicide in the elderly. Suicide of the older adults account for 13% of those in the United States, which I think is too high of a number, especially when we can do things about it. But risks for suicide in the elderly or the older adults comorbid health conditions. So lots of complex health conditions. When patients have high blood pressure and heart failure and diabetes, a COPD, it's a lot. It's a lot on the body, it's a lot of stress, it's a lot of doctor's visits. Those types of things can certainly contribute to feeling poorly. Inadequately treated pain. People who are having lots of pain and we're not treating it to the maximum capacity, certainly those patients have an increased risk. Terminal illness, widowhood or social isolation, personality disorders, if patients have had prior mental health issues or prior suicide attempts or a family history, those folks too are at a higher risk. And again, I just wanted to bring that to everyone's attention because knowledge is power and prevention is key. Diagnosing depression in later life is challenging for healthcare providers because, as we kind of alluded to earlier, concurrent medical illnesses often have symptoms that overlap depression. So certain ailments on the body can cause fatigue, psychomotor slowing, loss of appetite, sleep disturbance, lack of sexual interest, and memory complaints. So sometimes when folks come in with other presenting concerns, we often don't think, hey, depression is kind of in our differential diagnosis. Maybe this is going on. And a lot of times, patients who have depression symptoms have somatic concerns. That means that they have something going on in the body that they come to the clinic with, but actually it's depression that's leading to those physical concerns. Medication side effects. As we age, oftentimes we're on more medications, and those can certainly have side effects that contribute to feeling fatigued, feeling tired, and sometimes we miss as providers that patients are actually experiencing some sadness and depression, and we're focused on those other medical ailments. Impaired communication, when patients have trouble hearing, when they have trouble verbalizing their needs and their thoughts. Sometimes as providers we have difficulty. And this is huge. As you know, doctors are getting busier and busier and busier, and sometimes when you go to the clinic setting, they have 20 minutes, to talk about your healthcare concerns, and it's hard because when you have diabetes or something like that, we tend to focus on that problem at hand, and then we forget, or if you don't bring it up, sometimes we don't allude to that in our clinic visit. And then what we talked about at the beginning, just there's this perceived stigma. So when patients have depression, they equate it with mental illness. And I'm here to say that certainly, like I mentioned, there's physiologic change in the brain that causes depression. So I want to, again, try to normalize it, that a lot of patients experience this and there shouldn't be this stigma that we should, kind of not talk about, because I think there's so many great things that we can do about it to improve quality of life. When you go to the clinic, when you see your doctor or your healthcare provider, oftentimes the staff will ask you a few questions. We pretty much screen everybody. So I found some screening tools that you might have experienced when you go to the doctor. This is called the Geriatric Depression Scale, and it consists of 5 questions. And if you answer no to question 1 or yes to the following questions, 2 out of 5 can certainly suggest a depression diagnosis. So I always ask patients, are you satisfied with your life? Do you get bored? Do you feel helpless? Do you prefer to stay home rather than go out and try new things? Isolation is something that we want to avoid. And do you feel pretty worthless the way you are now? So if patients answer 2 of those out of 5 of them, we think, hey, let's talk about depression. Let's talk about what we can do about it in the clinic setting to make you feel better. There are some other tools that we use as well, and these might be a little bit more common, or patients, typically this is what we use at Mercy. We use a 2-step screening. It's called the Patient Health Questionnaire. In light, we call it PHQ-2 screening. And if you answer yes to one of these questions, it actually kind of drives us to ask further details. But I always ask patients, in the past month, have you been bothered by feeling down, depressed, or hopeless? During the past month, have you been bothered, by, I misprinted there, little illness or pleasure, little interest or pleasure in doing things? And again, if you answer yes to one of those questions, then we delve in further and ask more questions. This leads us to a more in-depth questionnaire. It's called the PHQ-9. So instead of 2 questions, now we're asking 9 questions, and it actually gives us a scale. And so you answer these by, in the last 2 weeks, have you had little pleasure doing things? Feeling down, depressed, or hopeless? Trouble falling asleep or sleeping too much? Feeling tired or having little energy? Poor appetite or overeating? Feeling bad about yourself or your failure? Trouble concentrating? Moving or speaking so slowly that other people could have noticed? Or if you have thoughts that you'd rather, be better off dead or hurting yourself in some way. We score that. And so, based on scores, we talk about, hey, my patient might have mild, moderate to severe depression or severe depression. And based on the scoring, we talk about what's next. Do we bring you back in a month and talk about how you're doing after we talk about some things at home that might make you feel better? Do we talk about counseling service or medication? Because those are all options, and they're tolerated very, very well, even in the older adult. So treatments. I talk to patients about psychotherapy, big fancy word for counseling. Counseling is one of the things that we recommend first as a first line option. It's great to sometimes just sit down, have a safe haven to talk about, what's causing stress, caregiver burden, loneliness, those types of things. It's great now because a lot of these things can be done over the phone or over telemedicine, or you can sit down and talk to someone. But they find that psychotherapy or behavioral therapy or counseling is great. It's equivocal to medications. Oftentimes, though, used together, patients have the best benefit. So medication options, certain medications help balance hormones. And like I mentioned, cortisol, serotonin, all of these types of things that are floating around that could potentially be leading to depression can be modified by medications. Oftentimes we use medications like Zoloft, Celexa, Prozac. There's many different options, but they're tolerated very, very well. And what they're called is this SSRI, or selective serotonin reuptake inhibitor, and it basically works. These medicines work by increasing the serotonin in the brain. Serotonin is a mood stabilizer, so the more we have of it, it helps us feel better. And these medications prevent serotonin from going back into the neuron, and it keeps it available for the brain to utilize. But as mentioned, using these options together often have the best benefit. Starting these medications on patients, I start a lot of them on folks. We start really, really low doses. Side effects, it depends. Sometimes patients can have a little constipation, sometimes they can have a little bit of weight gain, sometimes they can have decrease in their sexual drive. However, in low doses, they're tolerated pretty well. And if one doesn't work, we try another one. Oftentimes, these medicines will all have big black box warnings on them that say, hey, if you give medicines like this to your patients, make sure you inform them that sometimes starting medications like this can increase depression. It can actually lead to suicidal thoughts. So I warn patients every time I start these medicines. I've been doing nursing for 20 years, and I've only had a handful of patients who have had weird thoughts or weird dreams. And they call me right away, we stop the medication, we try something different. But I always warn folks that, hey, tell a loved one that you're going to start a new medicine. Make sure someone knows that we're going to try this medicine. And as I mentioned, they work really well. Oftentimes there's a delayed response, so it takes about 4 to 6 weeks for these medicines to actually stabilize and stabilize your mood. However, they've been proven to really improve depression, and they're great for anxiety as well. So sometimes, especially women, sometimes we have a little bit more worry and anxiety, and that leads to more depression. And these medicines cover kind of the gamut of both. Can depression be prevented? Although most cases can't be prevented, I talk to patients about healthy lifestyles and how that can have long-term benefits from your mental well-being. Being physically active, even though sometimes it's difficult, being physically active, trying to maybe get out, do some exercise, walk, eating a balanced diet, those also have been proven to really prevent depression. Low sodium diets, the DASH diet. We talk about this in hypertension. I tell everyone that comes in with high blood pressure, try DASH diet, which is a low sodium diet. But actually, that also has been proven to decrease risk of developing depression later in life. This is easier said than done. I surely don't get 7 to 9 hours of sleep each night, but we encourage folks to try to get 7 to 9 hours of sleep each night. And I tell patients about sleep hygiene. Sleep hygiene is something that we try on patients before we initiate any medications. Going to bed at the same time every night, waking up at the same time every day, making sure that we're using the bed only to sleep. We're not staying in there all day or napping in there all day, because the brain has associations. It's really powerful. Has an association with the bedroom and going to bed. So I have patients turn off all electronics, turn off the television, try to do things that aren't as stimulating to the brain prior to going to sleep. And in women and men, getting up to urinate overnight is often a problem as well. So talking to your healthcare provider about, hey, this is what's waking me up at night, because I know that sleep is so important when it comes to all kinds of health concerns, but depression as well. Staying in touch with family or friends. I think COVID has had an effect on all of us, and as you know, and I'm sure you've seen the research, depression rates and mental illness and everything, alcoholism has gone up during this pandemic. So trying to stay in touch with your family and friends has been difficult. We couldn't see them face to face or be in a room with them. Now I think things are improving, but COVID has certainly increased rates of depression in our nation. Participating in activities that you enjoy. Trying to. I'm proud of you all for being here, because I think just having some place to go, getting out of the house, and that's important. It's really important. And then let friends, family, your medical team know if you're experiencing signs of depression. Like I said, it's hard to talk about. It is hard to talk about, but I encourage you to let someone know. And then supporting family and friends with depression. I encourage patients to seek medical treatment and comply with the medical treatment. I encourage you to be an advocate for your health. And if your doctor or your practitioner, like myself, if we're not asking the questions about, hey, how are you feeling? How's your mood been? How have you been sleeping? That you bring it up in a conversation. And that if you're feeling depressed, I would just be downright honest and say, hey, I think I'm having some signs of depression. Because too often, we try to quickly see a patient and focus on their most acute needs. And sometimes, and again, I'm at fault for this as well, sometimes I focus on blood pressure, or I focus on diabetes, and I focus on lipid panels and things like that. And I don't bring into consideration that, mental health, depression, overall mental well-being really will affect your overall health. And so we have to provide a holistic vision of patients and how we treat them. So again, I just encourage folks to be advocates for their health. Help family and friends set up medical appointments and accompany them to the doctor's office, because there's power in numbers, right? Sometimes it's easier to go to the doctor when you have a friend, if you have a loved one. I have many women come in with their women friends and just say, hey, I'm concerned about so-and-so. She just hasn't been herself lately. I had a patient come in the other day with her mother, and mom said, hey, she just hasn't been herself lately. And sometimes when it's not easy to say ourselves, sometimes someone can advocate for us. So participate in the activities a person likes to do. So if you have a friend that you feel is not feeling well or having signs of depression, do things they want to do with them. Again, just being active together, any physical activities can be great and mood boosting. And really, that's all I have this morning. I wanted to close with a quote, just because I think this is so powerful. But it says, everyone you meet is fighting a battle you know nothing about, so be kind always. And Robin Williams said that before he passed away. So thank you so much for attending. I hope you got a little information. I know that the library has placed books and things about depression right under this audio-visual media. So if you have any sort of further wants to learn and educate yourself, I know that they've pulled some books for you. So questions, what can I answer for you? Any experiences, personal experiences that you wanted to share?